will be sharing my experience of 15 knees, which I have done using 3D CT-based software system. I am planning accuracy of pre-operative prosthetic component sizing using knee 3 with a 3D CT scan-based system in total knee arthroplasty. So as we all know, there is importance of accurate sizing. Initially, we were using X-rays for templating. Long leg X-rays were taken. So sizing of implant is an integral part for successful knee replacement. Sizing mediolateral, anterior, posterior, both are important. Oversizing the implant will lead to stuffing of the knee and restricted range of motion. Undersize of the implant will lead to higher stress on the bone cement interface and notching in the femur. So initially 2D templating methods based on X-rays were used with hip knee ankle axis, and templates like acetate templates or digital templating was used. Their accuracy was to the tune of around 60%. We were using it to predict the sizes of the implant. With further advent, we started using 3D systems, but it was, we can get all the 3D anatomy, but it was cumbersome, like we had to send it to some place, distant place to get the zigs, which we were getting in around 7 days or 2 weeks to perform our surgery. So like the system which we are using now in Shelby Hospital, Mohali, it's a 3D CT based system. It is Ortho 3D knee 3V system. I have done it on 50 patients. So what is different in this system is we can get 3D CT based planning, and we can get a modular customized jig also, which we can use in about 1,000 to 2,000 patients. So this is a process. First we get the DICOM files of the CT scan, then from the DICOM files we generate the 3D models. It is a surgeon who can plan on that bone model, whatever sort of cuts we need, whatever rotation we need, as a surgeon we can plan. So with the help of anatomical surgical landmarks, we can find the perfect implant match for particular knee. We can go with any sort of alignment, mechanical alignment or kinematic alignment, functional alignment, by taking the cuts which we want. So in our study, it was to the tune of, accuracy was tune of the 80% in the sizes. There was plus minus 1 or with plus minus 2 sizes, we can get about 100% results. So what we were able to get was, on the basis of our planning, we were able to get this jig. This jig is important. This is available in a box, which will be available with the surgeon. On the 3D CT based models you can plan, and after that there are, as we can see in the lower part, there is an area for the bush. This is a posterior bushing for external rotation or internal rotation. So depending upon the findings which we find in the CT scan planning, we can plan our bushes, which are available from 1 mm to 10 mm to set the rotation of the component. And like we see up, there is distal bushing for varus and valgus angulation. So as per our planning, we can plan our varus valgus cut in whatever alignment we want, mechanical alignment or kinematic alignment. We can plan with the bushes in which varus angulation or varus angulation we want our cut. So there is a stylus for AP distance measurement and flexion extension positioning of the femoral component. So with this is extramedullary jig. This is for the areas where we can use it like without any intramedullary approach is not required. It's an extramedullary jig for the femoral component. So when we can easily plan and do it. It is like pre-operative computer navigation. So we plan before going to OT, and there we don't need to use any intramedullary jig. So if even if we don't have computer navigation in OT, we don't have any robot in OT, we can use this jig for our cases where extramedullary approach is required. Like with intramedullary nail, with any femoral deformities, we can use this jig very easily. And with planning beforehand, there is on the basis of CT scan based software where we can, ourselves as a surgeon, we can plan. Ourselves as a surgeon, we can plan that surgery. So this system is basically, we can say this is surgeon driven planning and execution system. Pre-planning gives a better edge to the surgeon. With this system, we can use any implant, any company implant. So it's an open system, all available Indian and foreign implants can be used. Main is with the 3D planning, we study the native anatomy of the patient and the needs of the patient. So depending upon that needs, we can plan our cuts and we can set the bushes on the jig as per our plan and take the cuts. What I have seen is with this planning, my soft tissue releases, they have become less than 50%. So as there is no violation of the femoral canal, so blood loss is less, as well as we are able to do surgeries in the complex cases where we will be needing computer navigation or robotic system. So it's a very cost effective for the patient. It doesn't add any additional cost for the patient, and at the same time, we can use the advantage of the technology, and as well as human intelligence, as a surgeon intelligence also takes care. So it's a better accuracy and precision as compared to conventional TKR. Thank you.